related disasters on early marriage and reproductive health in Bangladesh. It is basically chaired by Dr. Faria Hassin. I'm just providing a little bit of a support, but it's her session. We have 3 speakers lined up, but unfortunately, as I said, due to some miscommunication from our side, human errors, we are very sorry. So Dr. Tay is not able to join us. She is teaching at this point in time in Bangkok. We have Dr. Fariha Hassin here from Bangladesh. We also have Dr. Manjur Hussain. So currently Dr. Manjur Hussain is on his way to home. So hopefully if there is no bad traffic jam, he should be reaching home in time to join as a 3rd speaker. Okay, so if we move to the next slide. Next slide, please. Yes. Next, the next one, just the housekeeping slides.
Yeah.
Okay, so we have this one housekeeping slide. I just want to remind everyone that, if you don't mind, please mute your mic for the entire session. Unfortunately, I can't, and you could hear my dog barking at the background. So apologies for that. And if you have any question or comment, please, you can raise your hand, but we would prefer that you do that once the presentations are done. So you could drop it on the chat box. We have a chat manager, Fahim. He is keeping an eye on all your comments. This session is going to be recorded, as we are been told by the UNOCHA, and we will take one group photo. If you would not like to appear in the camera, please, you can turn your camera off. And again, during the time of the recording, during the time of the session, as I said, the session is going to be recorded. If you do not want your face to be shown, turn your camera off. That will be fine. And each session is timed. But as I said, we are running 30 minutes late today. We are really sorry about this. But otherwise, each speaker will get about 10 minutes to speak. Okay, so I think this is our housekeeping slide, and I think that's it. And then we will start the session. So you can move on to the next slide. Yes, I've already done the introduction. We have 3 speakers. I'm hoping that Dr. Manjur can join. And as I said, Dr. Tay can't join today because of this problem, but I will be shadowing her. So I will be presenting her slides. After the session, we have a Q&A. If you have any questions, that's the time we will be addressing your questions. And if we run out of time, we will take your question and we will get the answer from the relevant speaker and we will post it on our website, ADN website, and you will be able to get your answer. I think with that note, we can start the session. So I am the first speaker in terms of introducing the Avoidable Deaths Network and the UNOCHA's Humanitarian Networks Partnerships Week conference. As you would know, it started this week. And this is our second virtual session. So my name is Nivedita Ray Bennett, and Nimra, we can't see the full slide. So my name is Nivedita Ray Bennett. I'm a professor of risk management. Hideyuki Shiroshita and I found the Avoidable Deaths Network. This network is based at the University of Leicester in the UK, where I am based, and Kansai University in Japan. So Nimra, we lost the slides, unfortunately. If you could share them, please. Okay, so once again, esteemed colleagues and our speakers and participants, thank you very much for joining our second session. This is our first time that Avoidable Deaths Network is offering the platform for the UNOCHA's Humanitarian Networks Partnerships Week conference. We received 5 abstracts, 3 are virtual and 2 are in person in Geneva next week. And this is our second session. Next slide, please. And the UNOCHA's conference is taking place during the Avoidable Deaths Network's global campaign. So I'm going to introduce or tell you a little bit about our global campaign as well. So the next slide, please, Nimra. Are you there, Nimra? Or Nimra is based in New Zealand, so I'm not sure whether there's a connection problem. So Kelly, if we are having problem at that
Can you
end,
see the slides? I'm sorry. Can you see the slides?
I can't see the second slide. I mean, the full slide version is gone. That's okay. But if you could share the second slide, please.
Okay. Just a second. Can you see it now?
I can't see. Yeah, go back to the previous slide. I can see now. So if you go back to the previous slide, please.
Yeah.
Yes, that's it. So a little bit about Avoidable Deaths Network. It was launched on 12th of March 2019 by Dr. Hideki Shirishita and myself at the 4th Summit of the Global Alliance for Disaster Risk Institutes in Kyoto, in Japan. ADN is a global local membership network of experts, practitioners, researchers interested in avoiding human deaths from natural hazards, naturally triggered technological hazards, and human-made hazards in low and middle-income countries. But we also work in high-income countries. I'm based in the UK. Hideki is based in Japan. We also have collaborators in Canada. ADN has more than 1,000 members spread across 94 countries. And ADN exists to help policymakers, researchers, practitioners, and at-risk and high-risk vulnerable populations to make better decisions to save lives and reduce injuries to achieve sustainable development. We understand that avoidable deaths are premature deaths that could be avoided through preventable, treatable, and risk governance measures. We can move to the next slide. And the next slide, please. Thank you. So on 13th of March 2023, we launched our global campaign called International Awareness Day for Avoidable Deaths. We launched this in collaboration with the city of Izumiotsu. On the top, you could see the city's mayor, Minamide Kenichi, and the global headlined by the United Nations head at the time was Mami Mizutori. The global campaign is celebrated annually throughout March, and we invite you. I know we still have the month of March going on, and these UNOCHA sessions, we are very lucky that they coincided with our global campaign month. So if you're interested to celebrate our global campaign, you're most welcome to do that. We have our own, we have a global campaign website you can look up, or if you can't do it this year, you can always join us next year. This is a 10-year global campaign, and on the 11th year, we will drop the word day. So we will just call it, we will drop the word awareness, and we will just call it International Day for Avoidable Deaths. Because our members are spread across 94 countries, so we don't only celebrate on 12th and 13th of March, but we celebrate throughout the month of March. And this is our second year, and we are celebrating the global campaign across 20 countries with more than 50 plus activities. If you're interested to find out more about the global campaign and the way our campaigners are celebrating this campaign, please, you could follow us on LinkedIn, also look up our news item page, and also on Instagram. We can move to the next slide, please. So a little bit about the purpose of this global campaign, basically fourfold. So number one, we want to raise the visibility of disaster deaths, especially indirect disaster deaths. Indirect disaster deaths are currently not focused by UNDRR or the national governments, but we are interested on indirect disaster deaths as well as missing persons. Number two, we are also interested through this global campaign to raise the visibility of the causes and circumstances that lead to disaster deaths so that context-specific interventions can be put in place to save lives. We would always hear that 10,000 people died in a super cyclone in 1999, or you would have heard that 15,000 people died in the Syria, Turkey earthquake, and so on and so forth. But often we don't hear what is it that led to the deaths, and that's what we are interested. So there might be one medical cause of death, could be drowning, could be snakebite envenoming, could be waterborne disease, but there could be 100 circumstances, and that's what we want to emphasize and highlight through this global campaign and also through our everyday operations. We try to understand that. Number three, we want to promote this global campaign slogan: disaster deaths are avoidable, and they are avoidable through preventable, treatable, and risk governance measures. And finally, the global campaign also aims to value the lives saved and reflect on the achievements of saving lives. This year, we introduced a new award called ADN Hero Award, and this is about individuals who are taking action to develop frugal innovations to save lives. And this year, the award went to a lady in Pakistan called Tahira Khan, and she came up with a really frugal innovation of constructing fences around wells to save life from well fall. And it has been fantastic. So we will be handing over the award to her on 31st of March. And if you know any such innovations that individuals are undertaking in different villages, towns, and cities, please let us know. We would like to, appreciate the work that they are doing by saving lives. So we can move to the next slide. So this year, the theme is do one thing. So you could do anything. It could be a webinar, rally, competition, so on and so forth. We can move on to the next slide. And to mark the global campaign, we have developed quite a few cultural assets. They're available on our website to download. We have 13 key global messages. You don't have to use all 13. Just cherry pick the one that you think is relevant to your context. We have a guidance for campaigners handbook. It's available to download. We also have this graphic, disaster deaths are avoidable. It's a stamp. You can download it. And also we encourage our global campaigners to use this hashtag avoidable deaths day. We also have dynamic toolkits for capturing the causes and circumstances, and this toolkit is it is dynamic, and we keep updating it. So if you need any of those things, you can get in touch with us. So the next one, please. So, it's important to know why we are celebrating the global campaign and why we should reduce disaster deaths. I mean, most importantly, if you start looking into the causes and circumstances of disaster deaths, you would see that the burden of disaster deaths is largely carried by the socioeconomically vulnerable section of society. And I think through this campaign, we try to redress some of the social injustice and also promote some sort of equity, wherever we can, by modifying risks and giving agencies and building the capacities of the high-risk population. And I think this is an absolutely amazing quote by Dr. Manu Gupta, also the winner of Sasakawa Award. And he said that each life is a treasure, and each life that can be saved from preventable disaster death ought to be saved. It is our combined responsibility. But furthermore, reducing disaster deaths gained traction in 2015 when the Sendai framework launched the 7 global targets. And the first 2 targets are reducing disaster deaths by 2030. And the second target is reducing the number of people affected by disasters by 2030. And these 2 global targets work in the interface with several sustainable development goals, such as number 3, 9, 11, and 16. So our global campaign is very much aligned with this Sendai Framework targets A and B, and ADN is also a member of the United Nations Sendai Framework's voluntary platform. And our commitment to the Sendai Framework and the UNDRR is on these first 2 targets. And our global campaign directly contributes to that. So we can move to the next one. Yes, if you want to find out more about ADN, you can look up on our website. You can follow us. We also have an ID for AD web page, and you can find more from our website. So I think with that note, I am going to stop, and I will invite our speakers. So our first speaker is Dr. Fariha Haseen. So Fariha, over to you. If you could also introduce yourself very briefly. And Nimra will run the slides. So thank you very much, everybody, for joining.
Hello. Thank you so much, Dr. Nivedita. Please.
Hi, before you speak, Dr. Faria, can we please, I would just request all participants to switch on their cameras and show a bright smile for a photo, a quick photo. Thank you. One more minute. Trying to take everyone. Great, thank you, everyone. Thank you. It's done.
Thank you, Dr. Nivedita Rebenet. So, good afternoon from my countryside to everyone. It is my absolute pleasure to welcome you all to this important session on the impact of climate-related disaster on early marriage and reproductive health in Bangladesh. Hosted as part of the Humanitarian Network and Partnership Weeks, HNPW, by the United Nations Office for the Coordination of Humanitarian Affairs, UNOCHA. We all know that climate change is no longer a distant threat. It is a lived reality for millions across the world, particularly in disaster-prone regions like Bangladesh. Recurrent floods, cyclones, and rising salinity level are not just environmental concern, they are profound humanitarian and public health challenges. They disrupt livelihoods. Please don't change the slide. When I will say the next slide, then you will change, please. Yes, please keep in the title slide. Thank you. So they disrupt livelihoods, force displacement, and increase vulnerabilities, and disproportionately affecting women and girls. At the heart of this session is the urgent need for climate resilient interventions that safeguard the reproductive health and rights of women and girls. Throughout this session, we will explore critical questions on mitigating climate-induced reproductive health risks. Our distinguished speakers will shed light on these critical issues, presenting evidence-based interventions and success stories from the field. By aligning our efforts with the Sustainable Development Goal, particularly SDG 3, good health and well-being, SDG 5, gender equality, and SDG 13, climate action, we can work toward more sustainable, just, and resilient communities. I encourage all of you to actively engage, ask questions, and share insights. This is not just a discussion. It is a call to action. Together, through research, policy, and practice, we can drive meaningful change. Thank you for being here, and I look forward to an encouraging conversation ahead. Now, I am going to present the session which the topic I'm going to talk today, that is the climate-driven displacement and child marriage, assessing sexual and reproductive health risk among migrant families in Dhaka's urban slum. I am Dr. Fariha Hasin, Associate Professor, Head Division of Reproductive and Child Health, Director Center for Gender and Women's Health Research, Department of Public Health and Informatics, Bangladesh Medical University. Next slide, please. So, climate-induced migration is increasingly recognized as a driver of social vulnerabilities, particularly in urban slums. In Bangladesh, river erosion, floods, and other climate hazards force rural families to migrate to urban areas for survival. However, this migration often exacerbates socioeconomic challenges and entrenches harmful social practices, which also includes the event like child. Next slide, please. So we would like to explore the intersection of climate change, migration, and adolescent reproductive health in urban slums. We all know that adolescents in these communities face heightened risks to their sexual and reproductive health due to limited access to education, healthcare, and economic opportunities. This study explored the interact to identify actionable factors influencing early marriage practices and reproductive health outcomes among climate migrant adolescents in Dhaka's urban slums. Next slide, please. Next slide. So if yes, you can show the whole slide, please. So if you see the study side, we can see that there was a slum which called Duari Para, and it is located in the central Dhaka, where we have conducted this study. The study population and sample size. It was a qualitative study, explored factors influencing child marriage practices and their sexual and reproductive health consequences among climate migrants in Dhaka's urban slum. We have conducted 27 in-depth interviews with married and unmarried female adolescents those are the family members of the climate migrants who came from other part of Bangladesh due to the different type of disaster, and now they are living with their family in the slum area. We also talked with 5 key informant interviews with those who are the parents of these adolescents and other critical stakeholders, like social leader of that community and slum area. We have conducted 2 focus group discussions, one focus group discussion with unmarried female adolescents, and another focus group discussion was with married female adolescents. We tried to explain the result, and we used the consolidated framework for implementation research, which we also call as CFIR, to explain the study findings for this study. And we have organized and present the findings across its 5 domains. Next slide, please. So here is the result. If you see the 5 domain of consolidated framework, that is CFIR model, the first domain is the intervention characteristics. So what is the intervention characteristics? These are the existing intervention, that is NGO-led campaign, and health services are there, but there are limited access for these climate migrants. There is also limited financial incentives for families to delay the child marriage. And we all know that as these young girls, when they get married very early age, so they also have a family and social pressure to get pregnant as early as possible after the marriage. So that is also a pressure for them. There are some misconceptions. What are those misconceptions? The misconceptions are about the effectiveness of legal protection against child marriage and inconsistent implementation of policies related to reproductive health and services. Here I would like to say that there are policies for reproductive health and sexual health services. There are also policies to prevent the climate change, but there are less alignment in these 2 issues. So this is very critical point to implement any intervention. Those are from climate change areas to the urban slum areas. And in the urban slum areas, there are also sometimes challenged to implement sexual and reproductive health services towards these married and unmarried adolescents. Now come to the second domain. That means outer setting. What do we mean by that? The outer setting we are talking about climate change induced migration. Due to river erosion and floods, these people were forced and not alone with their family to the urban slums to survive themselves. And that's why they have the economic hardship, increases child marriage prevalence as a coping mechanism. In the qualitative study, we have found that interviewees were telling as they have left everything or lost everything due to different type of disaster. So when they come in the urban area, almost sometimes some families, they do not have anything. That's why they think that if they give marriage to this unmarried adolescent girl, maybe some of their burdens will be reduced. And we know that in this part of the world, there is also kind of social norm and gender norm that is reinforced early marriage to protect girls from the harassment also. And it is sometimes also the community pressure as well. And for the outer setting, there is another point, that is limited access to healthcare services and contraception in slum areas. Though there are NGOs are working, and they are working very hard, but those who are adult married female, they are more confident to use these services. But when an adolescent girl becomes married, it is difficult for her to take the decision to do the family planning and go to the services with her own autonomy and take the services. So they also feel the challenge when they live in the slum. Now come to the third domain, that is the inner setting. What it tells us from this study. One is community structure support. That means child marriage is due to poverty and security concern. Sometimes the neighborhood people and the relatives also say or give the decision to that very family, that why don't you give the marriage or arrange the marriage of your young adolescent girl, because maybe there are some security concern. So the parents also become concerned. This kind of social pressure also give them some pressure to take this decision. Another one is parents face financial pressure leading to early marriage decision. Also, poor living condition and overcrowding make adolescent girls more vulnerable. When we observe their households in this slum, we have found that the living space is very narrow and sometimes the rent is expensive for them. So living in 1 or 1.5 room, 5 or 6 people, sometimes it is also challenging. So the space is sometimes overcrowded. And lack of education continuity, it is also a big concern. Due to migration, people lost many things. There is one thing which affects the adolescent girls and boys, that is the discontinuation of their education out of the school. So that also affects when they come from their own place to the urban slum area. Now I'm going to the fourth domain, that is the characteristics of the individual. So this means now I'm talking about the adolescent's autonomy. Sometimes adolescent does not have that much of autonomy to say no to their marriage, to say no to that they do not want to be pregnant, and also they do not have to say that decision that they want to take the reproductive and sexual health services. Married adolescents have limited knowledge of contraceptions before pregnancy, and also menstrual hygiene management is inadequate due to financial constraint. And if we have the observation of the slum area, we can imagine sometimes this is very challenging to have the proper menstrual hygiene management, because sometimes there is also a barrier in the safe water access and also the toilet facility. And lastly, in the fourth domain, that is the fear of social stigma in adolescent decision making. As they cannot take their own decision, sometimes they are being pressurized, and when they see that her friend also got married, then it also become a peer pressure to her, that why she is unmarried and she is living in the slum. So it is the peer pressure, it is the family pressure, sometimes it is the social pressure, it is the neighborhood pressure, sometimes it is a norm. So the last domain is CFIR domain 5 is implementation process. So it is saying that establish adolescent-friendly clinic with free contraception and menstrual health products is very essential. Basically, there are some NGOs who are working with the slum people, and they are distributing the contraceptives and information also. They are also distributing free sanitary napkin. But sometimes these migrant adolescents do not have the accessibility of these services. They also provide vocational training and job placement programs, and it is more accessible for the male adolescents, and also the strengthened awareness campaign to challenge harmful social norms. We have found that there are some community group in these slums who are talking about the harmful type of the early marriage and harmful effect of the early pregnancy, and also not what will be the harmfulness if they do not use any family planning methods, or if they do not do any space. And then enforcement of child marriage laws, right? Social safety net in Bangladesh, government is strongly working to prevent the child marriage. And this is an approach for the interministerial approaches. For example, Ministry of Education, Ministry of Youth and Sports, Ministry of Health, Family Welfare, Ministry of Education. So all the ministries are working together to prevent the child marriage. In Bangladesh, we also have the law to prevent the child marriage, and also from the Ministry of Health and Family Welfare, they are promoting that what are the bad effects or bad consequences physically, mentally, and socially and financially. So it is done.
Faria?
And my last point.
Okay, so if you could wrap it up, please. Yeah. If you could wrap it
Yes,
up in 30 seconds.
I am going. Yes, this is my last point. Engage parents in discussion about the long-term benefit of delaying marriage. So we have seen, and we are also proposing that the parents and other stakeholders and community members have to work together. Thank you so much for your patience hearing. So, Dr.
Thank you very
So I would like to mention Dr. Nivedita that Dr. Manjur is at his home. Maybe he can join with us. But before that, if I can request Professor Nivedita to do the presentation, maybe by that time, Dr. Manjur can be ready to give the presentation at last. Thank you so much.
Thank you very much, Faria. That's a very good news. So Faria, before we start, I just have one question. In Bangladesh, how does the government of Bangladesh define an adolescent age?
Yes. Bangladesh government is defining adolescent age, and we are very much aligning with the World Health Organization, that is 10 to 19 years is being operationally defined as adolescent age.
Thank you very much for that information. Okay, that's fantastic. That was really great, insightful research project that you are doing. Many congratulations to you and to your team. So we can move to the next one, which is me. As I said that I'm shadowing Dr. Tay. Tay is teaching, and it's all because of this time difference confusion. Started with UTC on UNOCHA's website, but it's our mistake as well. So this is the title of Tay's presentation, Quest for Sustainable Change-Making, Reproductive Health Kits for Disasters and Crises. So we started with the theme of Bangladesh, and we will continue the theme of Bangladesh for this session. Okay, so I am the principal investigator for this project, and Dr. Tay is the project coordinator. She joined my project 2 years ago, but the project has been running for more than 10 years now. We can move to the next slide, please. Okay, so to do with a little bit of the problem. So what is the problem? So you already heard from Faria Hassin, the problem with regard to menstrual hygiene, early pregnancy, unintended pregnancy amongst the adolescents, and she has been looking into the urban setup. Whereas I have been looking into similar problem, but slightly in a different context in Bangladesh, but in disaster-prone areas. So what is the problem? So the problem is high maternal mortality and morbidity, maybe in a global context, but not in Bangladesh. Bangladesh managed to achieve the MDG 5 in the MDG era. And for the Sustainable Development Goal number 3, they are working hard to achieve that target. So, but Bangladesh do have a high number of post-abortion complications in disaster context, although we don't have the statistics very well. But other than that, the problem is basically that my research has been looking into is unsafe abortions and post-abortion complications in disaster context, largely in low and middle income countries. And the problem is that, as you would know, due to climate change, climate-related disasters are increasing. And in fact, it increased 5-fold in the period between 1970 and 79 and to 2000 and 2009. But at the same time, the number of disaster deaths have gone down, but the number of affected people have multiplied tremendously. As you would know, the disasters cause unsafe conditions for women, especially women and adolescent girls of reproductive age group. Also, they lead to structural failures at health facility setups. So often there are stockouts, no medicines and supplies. Services are disrupted. In my area where I worked in Bangladesh, services are not provided, especially the reproductive health services are not provided during the time of floods. And this problem is not going to go down. The disasters are increasing in Bangladesh and in other parts of the world as well. So what solutions exist? So to reduce maternal mortality, UNFPA provides minimum initial service package reproductive health kits. So there are about 13 reproductive health kits available at this point in time. And this, especially where we were interested in kit number 8, which is designed to treat post-abortion complications during disasters and humanitarian crises. But there are some logistical problems because this kit is available only in Copenhagen. And we trialed that kit actually, and I will be showing it in the next slides, the different phases of this project. As I said, there are some logistical problems because the kits are available only in Copenhagen. So we have to purchase it from Copenhagen and bring it to a national context. And that's not easy because you have to go through customs clearance and there are various other logistical issues involved with it. So the kits are not available at a local level. And they're not available in Bangladesh or in India or other low and middle income countries. So there is a gap in the market. And health service providers, as I said, often do not have the stock to supply deliver reproductive health services during the time of disasters. I think we can move on to the next slide. Yeah, so these are the different phases that we have been through. So number one, we started this project in 2015, funded by International Planned Parenthood Federation's Innovation Fund. At that time, we trialed our intervention, which was called RHCC. RH stands for Reproductive Health Kit 8. Second C stands for capacity building of the service providers. And the third C is raising communities' awareness for the uptake of the intervention. And we ran this intervention in 2017 in Sirajganj district of Belkuchi Upazila across 5 primary healthcare facilities of the government of Bangladesh. And based on that, the intervention was evaluated and we found that 20% of the estimated population were able to access the care during the time of floods of 2017. And in fact, for the first time, the health service, especially the Upazila Health Complex, was open and was providing services to women. And we also found that 26% of health service providers did not have any training on menstrual regulation or post-abortion care, and our intervention was able to develop their capacity. And we also spoke with the beneficiaries during the time of the intervention phase, and we found that it increased the quality of care for these poor women and vulnerable young girls who accessed the care during the time of 2017 floods. Now, the government of Bangladesh told us that's brilliant, but it's quite expensive. So to scale it up, you need to reduce the cost. And the cost was largely this UNFPA's Reproductive Health Kit 8, which we procured from Copenhagen. So we started the second phase in 2020, where we decided that, okay, to reduce the cost of the intervention, the only thing that we could reduce the cost is by developing a low-budget reproductive health kit 8, where the supplies and medicines can be sourced locally and positioned locally. So that's what we did. We started developing a protocol during the COVID-19 time. It was funded by ESRC Impact Accelerator Account Fund from Leicester University, and also some funds from International Planned Parenthood Federation's South Asia Regional Designated Fund. So we engaged with more than 15 technical stakeholders. We spoke with users, beneficiaries, and we developed a protocol for these 2 kits. And these 2 kits are called Facility Kit, and the second is called Mobile Kit. So we, with further funding from ESRC Impact Accelerator account and ESRC's Commercialization Fund, we then started prototyping those kits from 2023. And during the time of the prototype, we just decided the volume, the weight, and the number of women that these kits could cater to. So the Facility Kit is designed to be prepositioned at a health facility level. It is more effective if the kits are prepositioned before a monsoon time, rainy monsoon season in Bangladesh. And the mobile kit is also designed to be positioned at a health facility, but service provider can carry it on their back to an emergency setup. So yeah, we finished the prototype phase in the month of February, literally last month. And from 1st of March, we started the commercialization phase funded by ESRC, AHRC's Accelerate Fund. I think we can move to the next slide now. Yes, so little bit of the features of our kits. So you could see on the top, Facility Kit, that's what it looks like. The mobile kit at the bottom. There is another picture. You would see that the mobile kit, although it comes in a cardboard box, but you could take the components out and put it in a bag. And the bag is like a delivery bag. So it's hands-free. The service provider could carry it as a rucksack, sit on a motorbike and go to flood-affected area or war-affected area, things like that. So it is portable. So the unique features is that, as I said, our kit components, which consist of medicines, equipment, supplies, education, information, communication, and materials, instruction guidelines inside that box. And they come in 3 different sizes, large, medium, and small, to avoid waste and also cater to the different health facilities set up in Bangladesh or in other low and middle income countries. So it is fully customized. The mobile kit is portable. They can be taken to hard to reach areas or in emergency affected areas. They are low cost compared to the UNFPA's reproductive health kit. By low cost, it doesn't mean that the components are compromised. So all the components for medicines equipment are very high quality. This high quality has been assured by our supplier, which is RH Step, very renowned NGO for sexual and reproductive health research. And also, this another uniqueness is that this kit has the potential to develop the ecosystem, the local ecosystem, wherever we are going to position this kit. Beneficiaries, that estimate you could see 14.9 million lives in disaster risk areas is based on Bangladesh. Bangladesh was our prototype area. It is designed largely for poor and vulnerable women of reproductive age. We have written 15 to 49. We've used the WHOs, but after listening to Fariha, and also another research paper that I read from Bangladesh, the adolescence is counted from 10. So maybe we might need to tweak our number. So it should be 10 to 49, but otherwise we usually use the number 15 to 49 years. Maybe in Bangladesh, it has to be 10 to 49 years. The customers, these kits are designed largely for government, health facilities setup, INGOs in Bangladesh. According to the family planning policy and program, menstrual regulation and post-abortion care is delivered through NGO and government collaboration. So some of the areas, especially in hard-to-reach areas, service, especially the reproductive health services provided through NGOs. So NGOs, INGOs could also be our customers, donors, pharmaceutical companies, private clinics, and hospitals. And the users are largely health workforce, so health workforce who are mandated for safe abortion and post-abortion complications. So it's not for everyone, but especially for the health workforce who are mandated to do this job at a national level. And finally, our kits adhere to the national guidelines. So if these kits are going to be sold in Nigeria, we will be tweaking, we will be customizing to make sure that it adheres to the national guidelines, because some of the medicines need to adhere to the national guidelines. So we will do that. So it's a very bespoke kind of service that we will be providing. So next slide, please. Yes, our future plan is, as I said, we were very lucky, very fortunate to get a new grant from ESRC, AHRC's ARC Accelerator Fund. It's for 6 months. So they are providing me training on how to develop, become an entrepreneur and commercialize our product, because I'm just a traditional researcher. I have not done anything like this before. So I'm going through 25 plus trainings, rigorous training that ESRC, AHRC is offering to me, which is, I just absolutely feel fortunate and privileged to learn about commercialization. The project is for 6 months. So over 6 months, I'm going through serious trainings. Tay, my project coordinator, is also going through lots of trainings. And then the latter 6 months, we have to implement it. So it is likely we will be launching a venture called Avoidable Deaths Lab. And under this kit will be provided along with the other services such as trainings, capacity building programs, if any of the customers are willing to purchase not just the kit, but also the other services. The goal, as I said, is to develop a sustainable business model. And to do that, I'm going through rigorous training. And also, our aim is to secure an investor by the end of 12 months so that we could start piloting. We will be piloting the kits in Bangladesh, but also investors so that we could somehow export the kits where it is needed the most, maybe in sub-Saharan Africa or some South Asian countries. So that is something we will be exploring over this 12 months period. The next slide, please. I think that's it from my end. So thank you very much for listening. And if you're interested to find out more about this particular project, we have a dedicated website on ADN, dedicated project page on Avoidable Deaths Network. So you can always, look up. And if there are any questions, if you think a potential customer, potential users, please drop us an email. I would love to listen and learn from your, inputs and technical expertise, because I don't see myself as an expert. I'm just learning as the process goes on. So I think thank you very much for joining our session. And we have our third speaker. So Faria, is there anything that you would like to say before we invite Dr. Manjur?
Thank you so much, Professor Nivedita Rebenet. I think I would like to add just one sentence. This is a dream project. So, and we are happy from Bangladesh that we are the part of this dream project, and it has become a global project. And I'm so much, I'm so much curious that I believe that this project will not only be implemented in certain countries, it will declare our strong commitments to those women, those who are in the reproductive age women, who are suffering hugely during the disaster. So if we can scale up this reproductive health kit in the government health system and also in the other health system of our country, I think the other countries can also have a good lesson from us. We are very much hopeful. We are very much optimistic. Now, the next step we are going to start. I would like to congratulate the whole team, the leader of this team, Professor Nivedita Ray Bennett. Let's see. And I'm very much hopeful that we are going to be successful. Professor Nivedita Ray Bennett, thank you so much for your effort. And please continue this effort with all of us. Thank you.
Thank you, Faria, for your kind and encouraging words. You're part of the team. Faria is also one of the investigators. Okay, so our third speaker is Dr. Manjur Hussain. I need to add a few extra text to Dr. Manjur Hussain, because Dr. Manjur Hussain has been part and parcel of this project, actually. He's advised us, given us technical inputs, technical expertise, and I've learned so much. And I'm so grateful that Dr. Manjur has kindly agreed to give us a talk. So Dr. Manjur will introduce himself, but I think just very briefly, Dr. Manjur Hussain is based at the Government of Bangladesh's Directorate General of Family Planning. He's a program manager. I think with that note, I'm going to stop. So Manjur Bhai, please switch on your camera and give us your presentation. Over to you. Thank you.
Thank you. Assalamu alaikum. How are you? Am I audible?
Well, yes, I'm very well. Thank you, Manjur Bhai. Walaikum salam. Thank you for joining, and we can hear you loud and clear.
Okay, thank you. Holy Ramadan Mubarak. I welcome all of you to my presentation regarding reproductive health and a crucial issue, that is salinity. We know salt is very much tasty, but in few cases, it's not in all places and not in people's salt is helpful. But we are living in Bangladesh. As we know, Bangladesh is a very much climate sensitive country in the world. Most probably, it is in 7th position in around the world in around 10 countries. So, lots of peoples in Bangladesh are suffering from climate change impact in Bangladesh, especially women and adolescents. Please, this is Dr. Manjur Hussain, Program Manager, Adolescent Health, working in DJP, that is Director General of Family Planning in Bangladesh. Next slide, please. Next. Okay. Salinity conditions in coastal areas of Bangladesh, especially already Nivedita I mentioned here, 15 million people are being suffering from these crucial issues. So we are trying to achieve our SDG goals, reduction of maternal mortality and all other reproductive health complications in Bangladesh. In these regards, I already mentioned here, Bangladesh is a deltaic plant. So it is affected by cyclones, storms, flat flash. You have already heard the name, that is that Sidor, then Bulbul, then Amphan, like that. According to a German was 2020. There's a global climate index in Bangladesh. We have ranked in the 7th position. So it is a vulnerable country. In this respect, women and especially adolescent girls in Bangladesh are very much crucial, and there is been very much dangerous positions to get quality reproductive health services in Bangladesh. The progressive salinity of water poses critical changes in public health problem, especially in reproductive health. Next. All of you know causes of salinity in Bangladesh, especially climate and sea level rises. Raising sea level cause saltwater intrusions and penetrations in the potable water in Bangladesh. Cyclone and storm surges. Natural disasters like I already mentioned here earlier, Sidor, Ailia, Ampan, lots of cyclones and flood flash happening in the Bangladesh few days ago. On the other hand, Bangladesh is very much popular for shrimp farming. For shrimp farming, large-scale shrimping farming increases soil and water salinity. And this is as well as reducing freshwater sources in Bangladesh that put enormous problem in reproductive health in Bangladesh that I'll see in the next slide. Okay. Next slide, please. Though in Bangladesh, salinity intrusions and reproductive health issues, not so much data over there, but I have tried to collect few information from the service-related data from our health facilities, what they have faced in the past few years. I have tried to accumulate few data over there from 2007 to 2009. If you see the slide, go to the slide. Salinity is very much related to pregnancy-induced hypertension and eclampsia and preeclampsia in Bangladesh. You know, not only in Bangladesh, it is throughout the world, but in my country, you know, the maternal mortality causes postpartum hemorrhage is a major burden on and around 31% maternal mortality happening due to postpartum hemorrhage. Then you come to the second cause, that is eclampsia and preeclampsia. 24% maternal death are related to eclampsia and preeclampsia. This salinity intrusion is a major contributing factor to eclampsia and preeclampsia that is happening in the southern western part in our country, especially Khulna, Patuakhali, Bhola, Borguna, Jalkadi. These are the major areas which are affected by salinity intrusion. So the data we have mentioned here, female admitted in hypertension in a district level hospitals in 2017, that is was 196. In 2018, it is 198, and 2019, that is 2000, it is increasing day by day. So this is the crucial health impact, climate impact happening in Bangladesh. Females with eclampsia and preeclampsia patient that was admitted in the hospital, it is also increasing day by day. So we can say salinity intrusion has a direct impact on eclampsia and preeclampsia, pregnancy and hypertension. This pregnancy-induced hypertension and all other things that is bring stillbirth, low birth weight, prematurity, and all other things, miscarriage also over there. Next slide, please. So what to do? What is the solutions? Actually, Bangladesh is trying to eliminate or reduce the climate change impact on reproductive health, especially maternal and adolescent health. So lots of things, lots of policy guidelines and strategy is taken in Bangladesh. In this regards, I have mentioned here few potential solutions how we can reduce the salinity intrusions over there and their impact on reproductive health. We have trying to, and we are doing awareness building activities over there to collect rainwater harvesting and pond sand filters so they can reduce their salinity level in their potable water and drinking water also. Regarding quality ANC and respected maternity care, in that regards, we are working with the communities to build awareness among the service providers and also service receivers, so they can timely came to our health facilities. They screen their health conditions and earlier detection of preeclampsia and hypertensive disorders, so we can go to the preventive measure to prevent the eclampsia and preeclampsia condition over there. Bangladesh government has given more emphasis on hard-to-reach areas, especially climate-prone areas. We have already taken initiative to ensure family planning services, maternal health services, and other reproductive health services over there. So we have developed a strategy for hard-to-reach area, family planning strategy for hard-to-reach areas, how we can contribute and give their desert services over there. And long-term strategies, desalination project already we have developed in few places, but not in so much. But Bangladesh government is very much concerned, and in Bangladesh Health Economics Unit, especially climate change unit, trying to address these issues, especially climate change impact of health impact and the maternal and reproductive health crises over there. Climate-related agriculture facilities, Bangladesh Agricultural University and all other agricultural facilities trying to develop climate resilience crop over there, so we can ensure the nutritional level for the maternal and mother and adolescent boys and girls. Lastly, policy and infrastructure development investment is going over there. Government and as well as NGOs and development partners has given more emphasis, especially UNEP, UNICEF. They has given more emphasis on to reduce the climate change impact on the affected areas. Not only that, already Nivedita rightly spoken here. She has presented over the reproductive health kits that we have developed. We are trying to incorporate this reproductive health commodities and kits in our program perspectives. Hopefully, we'll be able to incorporate this reproductive health kit in our health systems to give quality reproductive health services to our desert communities like mother and adolescent boys and girls. Next. Hopefully, this was my last slide, but this is from my side. If you have any questions, then I can give you the answer.
Thank you very much, Manjur Bhai. So, Faria, is there any remark that you would like to add to Dr. Manjur's presentation, and then we can open up the session for Q&A?
Thank you so much, Dr. Manjur. I think those who are participating and joining in this session, I must say that it's an eye-opening presentations we have done in this session. In this session, that how this salinity can affect the reproductive health of the people. So it's a huge, huge issue. So salinity is not affecting our daily life. It is also affecting the reproductive health of the woman. And if the woman's reproductive health is being affected like eclampsia, pre-eclampsia, we all can understand nationally and globally that it will also affect our future generation. That is, I'm also talking about the newborn. And when this newborn will be born, maybe that newborn will be low birth weight, preterm delivery, or maybe that newborn, when that newborn will become an adolescent, that this vicious cycle will going on. So I must thank you, Dr. Manjur Hussain, as he is from government. So he also mentioned some brilliant solutions also. What we really need, that very strong will, and we all need to work together, because from different parts of the world, we all are here to work for those women, those adolescents, those children who are waiting for us, who are waiting that we will raise our voice on behalf of them. Thank you so much, Dr. Manjur, for giving your time and for a brilliant presentation. Thank you.
Thanks to all.
Thank you, Fariha. Thank you, Manjur Bhai. So there were a couple of questions. So Elaine, I have already dropped I posted my answer directly to you because I'm conscious of the time. We've already taken 21 extra minutes from your everyday, from your precious time today, wherever you are. So if there is any question for Dr. Manjur or for Fariha, please feel free to unmute. We will spend about 2 minutes and then we will close this session. So anyone who is brave to ask a question, please go ahead.
Anyone can open their mic to make you unmute, and you can make questions. You can also make comments. We will be very happy to hear the comments from you.
Some
Anyone?
lovely
Please.
comments actually on the chat box. So it says, thank you, Dr. Manjur, for highlighting a crucial issue for female reproductive health. That's very good. We also have, thank you so much, Dr. Faria Hassin, Madam, for your nice presentation. It's fantastic. And then also we have some very encouraging comments from Elena for my project. Thank you, Elena. I don't see anyone raised. No one's hand is being raised. So I think we don't have any comments. Yes, thank you. So I think with that note, we are going to close this session. It's been fantastic turnout as well, 39 participants, We've had a little bit of problem because of the time difference, as you could understand and appreciate that our speakers were from 3 different countries, Bangladesh, UK, Thailand, so things were a little bit messed up. And as I said, this messed up began because we just somehow misunderstood the UTC, which was on the website of UNOCHA. And our advisor, Professor Aloy Harshmughal, is here with us. So Aloy and myself will convey this message to Peter Thomas, to UNOCHA. We are both going to Geneva next week. I'm leaving on Sunday. So we will convey this message if we could anyway make it a bit simpler for the international community to understand these time differences, okay? So sincere apologies for starting late, but other than that, thank you to all the participants for taking time and listening to our wonderful speakers. And thanks to my ADN team, Kelly, Nimra, Fahim, Sadia, who have worked tirelessly. And also special thanks goes to Dr. Riddhi from Bangabandhu Sheikh Mujib Medical University, who has been firefighting on her own and been trying to do things and settle things in Bangladesh. So I think with that note, a big thank you to everyone who worked behind the scene, and also thank you to the participants. And once again, thank you to Dr. Manjur Bhai, Faria and Tay, who could not join us, but in absence. Thank you and have a wonderful day wherever you are. And please stay in touch with Avoidable Deaths Network. Follow us, like us. We are on social media, so thank you.
Thank you. Thanks to all. We will work together.
Thank you very much.
For the women's and girls. Thank you.